I am talking on unhappy TKR. 10 to 30% of patients are dissatisfied after TKR without any known complication, and this is a matter of concern. So when patient comes to you with a pain or unhappy TKR, you have to give really time to it. Call them in the end of your OPD, but they're going to take your at least half an hour. And there could be reason of many reason of unhappiness. The main reason is persistent pain, which is normally after 3 months of index surgery. And the causes we classify extrinsic, they are not arising from the knee. Intrinsic, they are really from the knee. And psychological, or when TKR done in early OA, we call it look good but feel bad TKR. Extrinsic causes, because many times patient after surgery, they blame all their pains due to TKR. So you have to really look for any hip or spine pathology or extra-articular pathology and counsel them accordingly. And this should be done, I think, before pre-operative also, when you are going for surgery, because you have to tell clearly to the patient what is benefit you are getting after TKR. Diabetes is a risk. Diabetes is a risk factor, and 20% TKR, they get pain post-operatively 1 to 2 years, because there is a chronic systemic inflammatory, and these patients, especially diabetic, again you have to tell them pre-operatively that it's going to take more time than normal. Now, what are the actual causes of the problem, the painful TKR? We can start like biological, which are first is the infection. When any patient is coming after post TKR, first thing should be come in mind is infection, and we should rule out accordingly. Baseline CRP is helpful, as Bharat has mentioned in this. Baseline CRP pre-operatively, because some people, they have high CRP from the beginning, and then we get confused that CRP is persistently high. And finally, for the diagnosis in early, I trust on aspiration and cell count and following culture, but cell count is more significant, especially 3500 WBC in synovial fluid. Sometimes inflammation is caused, anytime we have missed inflammatory arthritis. We do not do routinely ANA, anti-CCP, or sometimes we miss this, and this is a cause of post-operative. We should rule out this. Also, whenever doubt intra-operatively and synovium thick and you feel it's better to take a biopsy and send for histopath. Rarely heterotrophic ossification I have seen. Osteoporosis again, if in X-ray you see the osteopenia, better to do DEXA scan, vitamin D, PTH and calcium phosphorus pre-operatively. Also, if not done and patient has knee pain, you suspect do it post-operatively. Neurogenic diabetic amyotrophy, I have a couple of patients. These are the diabetic patients. They get this all of a sudden the severe thigh pain around the knee, and that is due to post-surgical this diabetic amyotrophy, and which takes sometimes 3 to 6 months to go. Post-operative neuro, always you should look for this. Now, what are the mechanical problems? Most common is patellofemoral problem. Mild tracking is more, and followed by impingement, overstuffing, or Klunk syndrome, and the instability. Now, patellofemoral problem, if you see this X-ray, both they look good. The right knee is unhappy or painful for last 7 years. And once you do the skyline, which most of the time we do not do pre-operatively, also post-operatively, you see the most common cause of this is impingement or facetal impingement or mild tracking. Mild tracking, I would say, is very, very common. Instability, especially the flexion stability in anteroposterior and hyperextension. To test the flexion stability, make the patient sit on a couch with knee hanging at 90 degree and try to do the drawer test anterior posterior. If there is a significant anterior posterior and these knee are unstable in flexion, they get a lot of pain descending stairs, climbing stairs, and they are unhappy. Extension stability is very simple to detect. Tell them to make walk, and if it is more than 10 degree, knee is going hyperextension is painful. And both these situations, they require revision. This is another reason when patient lose movement, especially if there is a residual fixed flexion deformity more than 10 degree, and they are really unhappy patient, or loss of flexion due to surgical error or arthrofibrosis. Now, what a third category is when you did everything perfect, your X-ray is fine clinically, but still patient is unhappy, and we call them looks good, feel bad, and the reason is psychological. Patient has many have unrealistic expectation, and sometimes they have anxiety, depression. This unrealistic expectation is due to lack of pre-operative counseling. Sometimes we do not spend time with patient. We conceal negative aspect of surgery. We do not tell them the process of rehab, how much time is going to take. And sometimes we also do not tell that they are not allowed to squat or do the floor activities or indulge in sports, and that also leads to dissatisfaction or unhappiness. Other thing is excessive promotion. Now there's too much promotion, all kind of zero pain or zero stitchless, and there's a bombardment by promotion all over, and then patient thinks it's like an appendix operation. Today you do the surgery and tomorrow he'll be running around. And that also, if you do not counsel them pre-operatively, they are very unhappy. Anxiety, depression is, and those who are psychosomatic is well known, established. These patients have poor outcome. If you know pre-operatively, counsel them, especially their relative, and because they are going to give us tough time. Now, doing TKR in early osteoarthritis, when it's especially stage 2 and not bone on bone disease, these patients are highly dissatisfied. Up to 29% it is in literature. The reason is sometimes we miss the diagnosis. We are in hurry, we are just aggressive surgeon and we just do the TKR, and the reason may be internal derangement, some meniscal root tear or meniscal tear, or sometimes the missed inflammatory arthritis. Typically these patients are young patients, 55 or less, and they are very high demanding. Sometimes and these especially stage 2 OA, we should be very careful. These patients also have poor pain coping mechanism. They are suffering from fibromyalgia or psychosomatic disorder, and they think like the knee is the only misery in their life. So be careful about operating these patients. There are also published literature. What are the predicting factors, like patients who are going to get dissatisfied? And these are, they have listed here, like patient characteristics: mild to moderate OA, severe pain, however the range is full and good, desire to run to high impact, narcotic use, pre-operative, poor general function, poor mental score. So in conclusion, I would say pre-operative counseling for a right expectation is very important. Making right choice of patient, do not operate in early OA. Good surgical technique is the gold standard, and remember, a good TKR may give you 10 more patients, but an unhappy TKR will take away or at least 100 patients. Thank you.